Okay. So I think we'll go ahead and get started with panel number 3. Again, thank you for joining us for this third panel, Experiences from Other Early Adopter States. This is going to be moderated by Ms. Allison Hamblin, who is Vice President for Strategic Planning at the Center for Healthcare Strategies. At the Center for Healthcare Strategies, Allison focuses on program development and organizational planning activities. She manages CHCS's efforts under the CMS Integrated Care Resource Center, through which she also provides direct technical assistance to states pursuing health home programs. She manages the Rethinking Care program, which is an initiative to improve quality and reduce cost for Medicaid's highest need beneficiaries. And Allison has specific expertise in the areas of physical and behavioral health integration, consumer management, engagement, and complex chronic care management. Ms. Hamlin has a master's in public health from the University of North Carolina, Chapel Hill, and a bachelor's in biology from Duke. So we welcome the panel. Thank you, Allison.
Figure this out. Can you hear me now? Do I really have to hold this up like this? I'll try to speak down. I may look a little funny, but more important that you hear me. Okay, great. Well, welcome everyone. Always tough to be first on deck after lunch. Always tough to be right before lunch or right after lunch, but hopefully no one's in too much of a food coma and we can have a nice, robust conversation. We are fortunate today to have a number of folks with us on the panel who have experiences that will be valuable to the discussion we've been having throughout the day around the opportunity presented by Medicaid expansion to reduce disparities, particularly for criminal justice involved individuals. As states across the country are looking to capitalize on the many opportunities presented by Medicaid expansion under the Affordable Care Act, there's much to be learned from the states who have actually been out there and doing this under other authorities preceding the Affordable Care Act. And states such as those represented here today have been able to do this either through pursuing special waiver authority from the federal government or by expanding eligibility under Medicaid through state-only funded programs. And there are a whole number of states across the country who have done this over the years. And it's from their experiences that we can learn a little bit about the expansion population to inform our preparation for what this population's needs will be, how we can prepare the delivery system to provide services once coverage is available, and to help us anticipate what the unique needs of this population may be. Again, we're joined here by representatives from two such states, Maryland and New Mexico, as well as by a representative of the health plans that ultimately will be responsible for managing the care for the expansion population in 2014 and beyond. So let me give some more detailed introductions of our panel. First, Carlisa Hussein is Director of the Office of Minority Health and Health Disparities in the Maryland Department of Health and Mental Hygiene. This office was established to promote the reduction of ethnic and racial health disparities in Maryland. She and the office staffed the administration's 2011 Maryland Disparities Work Group that led to passage of the Maryland Health Improvement and Disparities Reduction Act of 2012. Dr. Hussein in this capacity oversees the development of the Maryland Health Disparities Plan and the State Health Disparities Data Chart Book. The plan is guiding the implementation of strategies that address the major disparities in alignment with the National Partnership for Action and the goals of the National Stakeholder Strategy. The chart book presents minority health and health disparities trends and progress for specific diseases. Her office also funds health disparities demonstration programs in 24 jurisdictions throughout the state. To Carlisa's left, we have Carrie Armijo, who is the Healthcare Reform Manager for the Medical Assistance Division in the New Mexico Department of Human Services. Ms. Armijo has been the Healthcare Reform Manager for New Mexico Medicaid since passage of the Affordable Care Act. In this position, she's charged with directing and managing implementation of the ACA provisions that specifically relate to Medicaid, including eligibility transitions, development of benchmark benefits, and coordination with the Health Insurance Exchange. Prior to this position, Ms. Armijo served for 3 years as a Special Projects Director for New Mexico Medicaid, managing cost containment and Medicaid reform initiatives. She previously held positions directing Medicaid adolescent health programs and school-based health center programs, and she's been with New Mexico Medicaid for 10 years. And last but not least, we have Thomas Johnson, who is President and CEO of the Medicaid Health Plans of America. Since 2004, he has served in this capacity. And Medicaid Health Plans of America, for those of you who aren't familiar with the organization, is the leading trade association that exclusively represents the interests of the Medicaid health plan industry. Prior to his tenure with the association, he served as Vice President of Compliance and External Affairs for DC Chartered Health Plan, a Medicaid health plan here in Washington. And during his tenure at Chartered, he also served 2 terms as chair of the DC Association of Health Maintenance Organizations and won a 2003 Leadership Award. Mr. Johnson's experience also includes serving as president of the District of Columbia Hospital Association and representing the DC chapter of the American Medical Association. He's a native and resident of Washington, D.C., and also a graduate of Tufts University and the Howard University Law Center. So please join me in welcoming our panel, and we'll get started with some discussion. So the first part of our discussion will focus on our state representatives here, and we'll have some conversation really to try and learn from their experiences around earlier expansions of Medicaid, around some of the issues that I raised earlier. And following that conversation, we'll turn to Thomas and talk more about what the health plan community is actively preparing for with respect to Medicaid expansion, and specifically in regard to the issues around disparities reduction that we are most interested in today. So to start in with a very specific issue related to the conversations we've been having today. Both New Mexico and Maryland are jurisdictions with major opiate abuse challenges. One would think that with access to Medicaid and increased treatment options, there would also potentially be a reduction in jail occupancy, again, to the extent these opportunities play out in the way that many of us hope that they will. So to start the conversation, based on the experience of your states, would love any of your thoughts on, has this played out? Have you been able to observe such trends either in Maryland and New Mexico? And Carlisa, we'll start with you.
All right. First, I'd like to say thank you for inviting me here. And as some other presenters said, they felt like fish out of water. I felt that way too. But now after lunch, I feel better. And after hearing some of the discussion, I can see my way here. And by the way, it's been very exciting for me. In terms of the question, in Maryland, we say we are have the planets perfectly aligned. Things are just going very well in that everybody's on board, from the governor to the elected officials, one of whom is here today, Delegate Shirley Nathan Pulliam, who's had a lot to do with pushing health disparities in the state, down to the secretary. And what has happened is, and I did interview my colleagues in the state to make sure I could answer some of these questions. So I went to the horse's mouth to make sure I got it right. So I'm pleased to say that that in talking to the people in the Medicaid program, and we do have a team working together on implementing ACA and also on implementing the Maryland Health Improvement and Disparities Reduction Act, signed April 10th. I'm so excited, I'll never forget that date ever. And it both specifically charges the whole state to move aggressively to address health disparities across the state. Now with this, I'm focusing more on the criminal justice population. So what I did learn, and much of this is in process, is that we're working with the primary adult care program that we have in place, and now we have added services to that, such that the includes treatment for addiction. This is new, including the opiate addiction that we've talked about, and coverage for specialty outpatient addiction services, such as methadone clinic treatment. And one of the things, I didn't get to talk a lot, I don't want to get off the question, but in the Department of Health and Mental Hygiene, where I work, our Office of Minority Health and Health Disparities has been brought to the table. And we're at the table now when these issues are discussed. So now I will make more of a point of getting involved in the expansion to the opiate population, because there's much work to do there. But that's one thing I can say, and I'll stop and let my colleague answer, and I'll pile in later.
Thank you. Can everyone hear me? Okay. I feel like I'm on a talk show because these chairs are so comfortable and there's no table. So pleased to be here today. I wanted to tell you all a little bit about our state coverage insurance program, which we started in 2004 under Medicaid Waiver Authority, which allowed us to expand coverage to adults, both parents and childless adults, up to 200% FPL. And we have the program is capped, and we have about 40,000 individuals covered under that program right now. And we're looking at that program and sort of with the understanding that if we do decide to expand Medicaid under the ACA, that population is sort of reflective in some ways of the larger newly eligible population. Right now, it's actually, we've done a few things to build up behavioral health and mental health services in our state, and to sort of build capacity. We're really looking at that now in anticipation of possible expansion. And we recently added Suboxone treatment to our coverage of the SCI population. The Suboxone has to be provided by a primary care physician or a physician that's received training. We do have, even though it's been added to the benefit package, access is sort of limited right now because of the training required by PCPs, and there's sort of a lot of requirements in terms of DEA liabilities and pre-authorization and reauthorization requirements. So we're looking at that and seeing if we can make it more accessible. We also added methadone treatment to our benefit package for Medicaid recipients, and those were both recently added. So unfortunately, I don't have a lot of data or information about direct links to adding those benefits as part of our coverage and reduced opioid addiction in the general population. We haven't really gotten there yet, sort of drawing those correlations, but suffice it to say that we're working on that, and we're sort of trying to build up what we think the important services are for behavioral health for adults, which hasn't generally always been a focus for Medicaid programs.
Absolutely.
And if I could add two more items to the efforts in our Medicaid program. One is that we're going to place eligibility workers in the state prisons, and our office will get involved with some cultural competency training, because that's one of the things that we promote and do throughout the state, so that we can get comparability of people in terms of ethnicity and race, and certainly sensitivity. The other thing is that when inmates leave the prison setting, they will not lose, when they enter, they will not lose their standing as a Medicaid enrollee, and it will stay until they get out, at least up until a year. And so that they will not have to start over and reapply. So again, this is new. All of these things are exciting, and our office will be involved in trying to look at the details of how that's done so it's effective and deals with a population. We have 45.3% minorities in the state. So, and we have to be concerned we have a fair number who are not clearly English speaking, so we have to deal with translation and interpretation.
That's great, very exciting. One point just to highlight for the audience, in case I think it was referenced earlier this morning, but prior to the Affordable Care Act, states that expanded Medicaid coverage to to optional populations didn't necessarily have to provide the full array of Medicaid benefits. So for states that have experience with coverage, there's a great degree of a high degree of variation in terms of what's actually covered. And so when you look back to these experiences of, again, early adopting states, it's hard to do an apples-to-apples comparison with what we can expect in the future, because in many cases there were caps on enrollment, and in many cases less than the full array of benefits were made available to these newer optional covered populations. And so that's just part of the context to keep in mind here. So just following on in the conversation, a lot of the interest of stakeholders around the Affordable Care Act and around Medicaid expansion is to try and predict who this expansion population is, what degree of criminal justice involvement they will have, what the demographics will look like in terms of racial and ethnic composition, what their health needs will be, and so forth, all with a mind towards how do we prepare the delivery system, design the right benefit packages, adapt our engagement and outreach and enrollment strategies accordingly. And one of the things we can look to states like Maryland and New Mexico for is any insights you have into who is within this expansion population. What do they look like on these different levels and so forth, that can help guide the preparation of states and stakeholders in other parts of the country. So, Carrie, perhaps we'll start with you this time.
Yeah, so I know that we have, our SCI program began in 2004, so we have years and years of claims data that is actually really beneficial to us as we sort of try and figure out who the newly eligible population will be, what services they'll need, and what we learned from SCI, and I know there's been a lot of focus on the mental health side here, but there's also a high need for, these people have generally been, according to all of our surveys, uninsured for at least 3 years prior to getting coverage under Medicaid. And when that happens, there's quite a bit of pent-up demand and high acuity, which just means that the services they need are more expensive. So what we saw with SCI in the initial years was a high need for high-cost acute care services and also for prescription drugs. And to this day, prescription drugs are the highest cost in SCI. We also realize that by keeping people on their prescription medicines, it sort of prevents other hospital interactions and so on. But we really sort of had this, now we're anticipating and we have realized that it's not just the mental health side. We have mental health services account for about 9% of our SCI expenditures. And I think we are going to build that up a little bit to make more covered. But we know that they are, uninsured and people who've had almost no access to health care coverage consistently prior to their coverage in Medicaid.
And I'll speak to that question a little bit differently. I looked at some data, and Maryland has about 72% of the inmates in Maryland prisons are black. And with that, we are looking at the rest of the population and how the chronic disease distribution is among them. And we're seeing a fair amount of similarity between the two population groups. So let me switch and talk about a recent review that I did of some draft guidelines on the exchange. And in that, we were adding policy recommendation to increase in the network of providers that could be part of the exchange, a requirement that they had to have a certain percent of their providers receiving Medicaid. Now, that's a little bit controversial, but we put it in because this is a draft. I love draft because then I can say what I'd like, and it also forces the conversation to take place among those who will make the decision. Where they will come out, we don't know, but we put in the draft 80%. That's
so
a
this
good
would be,
amount.
just to be, and recognizing it's a draft.
Yes.
So 80%, so at the provider level, 80% of the patients that they see?
No,
Participating plans in the
participating
exchange.
plans,
Gotcha.
yes. Because one of the problems, not only in Maryland, across the country, is that so many providers now are not taking Medicaid. So, that's a real issue. We understand why. The reimbursement rates are not as they should be for them. So as we build the exchange, we want to make sure that same pattern not accepting persons at that level doesn't carry forth, so we recommend putting that language in. We're also recommending putting in language to address the issues of cultural competency and translation and health literacy. I should have even mentioned that first because the more we look at it, health literacy is a real critical issue, and it goes two ways. It's health literacy not on the part of the client, the patient, or the inmate, but health literacy on the part of the providers. We always are not understanding and speaking as clearly in this field, and now that we're bringing a whole new set of the population into the system, we really have to pay much more attention on being health literate.
Absolutely. That's a nice bridge to our next question, actually, which is really around the need for specifically tailored engagement and enrollment strategies in order to be successful in efforts to enroll this expansion population, and specifically the justice-involved subset of the population. Again, bearing in mind that it wasn't necessarily the focus of SCI or the earlier expansion programs in Maryland, do you have any experience, either of you, on again whether such tailored strategies are necessary, and anything in particular that you found to work in your prior experience?
Yeah, I mean, I think those tailored enrollment strategies are very necessary. Typically, Medicaid until now hasn't really been focused on sort of people who are sort of entering back into society after being in prison or jail. This just hasn't been traditionally what we cover. We mostly cover women and children. And so expanding to childless adults, presenting sort of a new, I think, direction for Medicaid, and it's going to be necessary for us to sort of think about the ways in which we interact with corrections facilities and the criminal justice system to sort of enroll people right away and access and have so that they can have access to services and coverage right away. So we are doing that. We actually had a legislative subcommittee on medication-assisted treatment, and one of their formal recommendations has been that we work together with the corrections department to ensure that people being released from jail are enrolled effective immediately upon their release, and that if they have a need for medication-assisted treatment like Suboxone or Methadone, that they're immediately brought into connection with a provider that can provide those services right away. So unfortunately, we have limited access in New Mexico, so this will sort of play out and how many people will actually receive those services. But we're sort of looking at how we can do that. And I actually, listening this morning, had an aha moment that this just wasn't something that a lot of state Medicaid programs have been thinking about. And I think those of you who work in advocacy is something that I think bringing to the attention of your Medicaid departments is going to be really important. It's just not the way we think sometimes. And traditionally and historically, those aren't the policies that we're as familiar with.
And my comment is actually the same as what she's made. I'm not in the Medicaid part of the department. I'm around the hall from them. I'm in the disparities part. And just the conference and my being invited caused me to knock on the door about this issue. So, I mean, interesting things start to happen because they generated the answers. I asked, well, what are we doing as a state? But what's exciting is, and this is a point at which I can bring up another initiative that's underway, with the legislation that was passed this April, we have in it one provision to establish health enterprise zones in Maryland. And those are zones that have high poverty and high poor health. And what we're going to do is to apply target resources to a small set of zip codes, maybe 2 zip codes, hopefully not more than 3 zip codes, where both of these characteristics are there. In that, we're addressing the issue also of how do we reach out to different populations. So we're talking about the use of community health workers, lay persons from the community, training them, but there's some push and pull because they have navigator language in the exchange, and there's a whole nother definition for the navigators. Now, some of us in the health equity side of the world in the state says that we need 2 types of navigators. We need the navigators who are attached to the insurers and the navigators who are attached to the people, and they meet in the middle to really make sure we have a communication going back and forth. Now, when it comes to the prison population, I think a similar kind of thing needs to take place. We're already moving to put these eligibility workers in, but I would like another kind of person, because eligibility is a limited concept. It means filling out a piece of paper, and when it's complete, that you're done. So that's a challenge and a goal for us and others in the state to start having a conversation. What else can we do with and around the eligibility workers to make some real connections? My hope is, and we're on the verge of probably, we've just reviewed 19 applications for these HEZs. We have $4 million a year for 4 years to fund them in Maryland. And my hope now is to see how, once they are identified, persons coming out of the criminal justice system who may be returning to those communities get connected to the system. Because that's the idea of it's supposed to be a focus and a community family focus in that area.
That's right. And do you have the ability to track criminal justice related outcomes in these communities?
No, we don't have that now, so that's something we will track outcomes for persons served, because that's how the HEZ is set up. So if NAC can get the criminal justice population who may be returning to those areas somehow connected in, which is my aha moment for this event, I think, because the system is in place to do evaluation and data collection, because we're supposed to be able to show what difference these funds made in terms of changing admissions and readmissions of certainly chronic disease. Well, we can add return to criminal justice system. Give me another variable to measure.
Absolutely.
So, I mean, lots of ideas are in place. So that's why I say in Maryland, the stars or the planets, I forgot which, are aligned, and we're trying to kind of make all of this work and make it happen. So there's a lot that I think we can do in Maryland around this issue.
It's exciting. So you've touched on the next question a little bit in each of your comments already, but just to head into it a bit more deeply, this is around the benefits question. So there's been some talk throughout the day about essential health benefits and parity and what is required and what is left for states to determine as they implement Medicaid expansion. But all of these most of these conversations are still in play across the country with regard to what is covered. The good news is that, at least in the states that expand, that choose to pursue the Medicaid expansion, there will be some degree of behavioral health benefit in the mix, at least for the expansion population. And again, Carrie, you've made some reference to learnings throughout the SCI program that have led you to add some additional mental health and substance abuse treatment benefits over time. Can you talk more broadly about the experience you've had to date and what that suggests is needed in terms of the benefit package for this population?
Right. So I should clarify that right now the SCI benefit package doesn't actually even qualify as benchmark. So we know, because of the addition of essential health benefits, that we're going to have to beef it up. We haven't actually done that yet. And so we're looking at ways to do that in anticipation of what's going to be needed. And I just want to say that even though, the law includes mental health parity, and that's great and fantastic, it doesn't necessarily address which specific services are going to be needed. And I think that's one way in which organizations like this one can be helpful, because we don't necessarily know. I mean, I think, so we added Suboxone. We did add methadone for our treatment for our Medicaid population. We're looking at adding that to the benchmark as well. I'm not sure that we will. It kind of depends. But I do think that, we've got some other plans for like intensive outpatient services for substance abuse, some, intensive care coordination and care management. And then one big thing that we're doing is we're sort of in the process of re-procuring our whole managed care system right now. And one of the concepts behind that is health homes. And we actually are specifically bringing up behavioral health homes first. And so our new managed care companies will be charged with sort of assessing each Medicaid recipient to determine whether they should be served by a behavioral health home, and that behavioral health home would be in charge of all the intensive care management, transitional care issues, and sort of managing that. So they would, the behavioral health home actually will take that responsibility somewhat from the managed care organization and sort of have that be charged with that for those members. And so we're looking at all of those things, but I think the issue just in and of itself of parity doesn't really get to that detail level of what services are really needed. And so, as much as we think we know, it actually would be helpful to hear from other groups that have interactions with, corrections or, other entities that sort of serve that adult population, so we could have a better insight about what they actually need. So I don't think that, again, this is sort of a new realm for the Medicaid program, and so to know specifically how we can design our benchmark to sort of make sure it's meeting those health needs, I think would be really valuable input.
I hate to say it's almost ditto, even though we have a lot going on. It's at a high level. The details are still being worked out. What's good is that we're working with the Department of Human Resources, sort of our social services sister agency, and sitting down at a table with the governor's office. In Maryland, we have something called state stat. Everybody gets nervous when they hear that. And what that means is the department has to come and sit with the governor and a couple of geeky kind of people who look at the data and look at the change in metrics and ask, why is this number gone down since our last meeting? And everybody freaks out on the program side, but it's a good thing because everybody has to prepare. And in the state stat, there is a metric about the reentry. And I think that causes a table where this is going to be discussed. We, in terms of minority health, are not involved in that, but now pay attention to it because I'm involved in the overall state stat process. So I think that could be a vehicle to drive some of these other issues. In terms of behavioral health, that is a carve out in Maryland in terms of Medicaid, the way things have been operating. And now we've been working on, for the past couple of years, how to link that back together. So, you pull it out and you put it back. So we're trying to merge behavioral health with somatic care a little better. So that's the direction we're moving there.
That's great. And just also in acknowledgement of the need really, not just unique to the states here, most states are in the same position of really having a hunger to get to the weeds of what services work. And I think partially in response to that and in recognition of the need to have the conversations drill down to that level, the Center for Medicare and Medicaid Services just this week issued a letter to, I think it's an informational bulletin, but basically a letter to Medicaid agencies across the country offering support from partners at SAMHSA and compiling resources on evidence-based practices and just making sure that states are aware of additional resources available that can help identify and tease out the specifics of which services should be included in the mix and what should be promoted in these conversations. So I think we'll see more activity in this area, which is great.
Could I bring up one small thing that didn't know where it fit? But I have a particular concern about women in the prison system and in the jail system. I guess I'm one of those people who's still not quite sure the difference between the jail and the prison, but that's all right. The concept is there. And what I've heard from some individuals who volunteer in the jails in the Maryland area is that there's significant number of pregnant women in jails. And it seems that they're not getting the kind of care, at least from the individuals that's trying to work with them. And in some cases, they're kept in the regular population longer during their pregnancy. And those who may begin to have issues are not separated out and given the kind of care. So that's the area, at least for me, that I'm concerned and surprised to hear that. And as we talk in Maryland, I will be raising that make sure that we remember that women and pregnant women are in these settings. And I guess women get pregnant in these settings, and so lots of issues.
Great. Well, one more question for both of you, and that is around, and again, Carrie, it's come up in some of the things you already mentioned, and it's come up earlier in the day as well, around treatment capacity. And you can require that Medicaid-assisted treatment be in the mix, but if there aren't enough primary care physicians out in the community who can actually deliver those services or are qualified to provide that treatment, it's not necessarily meeting the spirit and meeting the goals of the benefit design, so to speak. So with that in mind, that's a clear example of a potential gap in treatment capacity that may need to be filled. Are there others that you all are aware of in your states that you think require particular attention as we prepare to enroll more and more individuals coming from the correction setting?
Well, for New Mexico, the big one, we don't have enough providers just generally. I mean, this isn't specific to this population, but we are looking at the ways in which primary care providers are sort of the first points of entry for a lot of people to get access mental health services and medications. So we're sort of looking at how we can build that and build upon our primary care network. Ideally, those services are integrated, and it would be great if the primary care providers work side by side with the behavioral health providers, but we know that that's not the way it works right now. And so we're trying to sort of focus on integration as much as possible, but also recognizing that the primary care side is usually the point of entry. Just one of the reasons that I'm stating our reluctance about the methadone is that we only have 11 clinics in our state, and we've got a very large geographic state. So we are actually transporting people daily. We know that it's a daily benefit and that people generally need it for life. So it's really complicated if you expand a benefit, but there's just no access to it, and how that impacts your costs and everything. It kind of gets really difficult. So, that's going to be a challenge. A state like ours just doesn't have the capacity even for the current uninsured. So we're really struggling with that one. I think stay tuned and we'll try and figure that out.
Yes, that's quite a challenge, even though Maryland has a little more resources, but they're situated in certain areas, and we have our share of rural areas. So one of the things that we've done in this new program that's about to be launched, the Health Enterprise Zones, is to use the loan repayment program, that opportunity that's there. And we have both the federal loan repayment program, and we have 2 Maryland loan repayment programs that are in place. And we're looking for ways to maximize the use of the federal funds. One thing that we recently did, because the way we were implementing the federal loan repayment was just for physicians. And of course, we all know that you can, other kinds of providers could be cycled through that system. So with the effort, the state has gone and gotten the permission to use social workers, nurses, and others. So that's going to be good, because it's a little costly to go just with the physician model. So, and in some cases, other kinds of workers are even more appropriate. The other thing that we're thinking about is the issue of transportation for certain areas. That's a huge issue. You've mentioned that, and we've got to pay attention to that, how we work that in and pay for that. And then thirdly is the outreach workers and community workers and translators, because we have a fair number of persons where English is not their primary language, and we have to work through that.
Great, excellent, thank you. I'm going to turn, Thomas, to you now, bring in the health plan perspective into the conversation. And first question for you is, what do you see as the specific role that Medicaid health plans have to play in reducing health disparities in particular as we approach expansion?
Well, reducing disparities really is one of our core missions. Looking at the populations that we serve around the country, I mean, we really monitor and have a lot of data on the disparities that exist with the populations that we serve versus the population that, gets commercial insurance, private insurance. And so the disparities are very real. The issues surrounding access to health care play a role in that to a very large extent. And so, the contracts that we have with the states, the partnerships that we have with the states really revolve around trying to reduce a lot of those gaps that exist with regards to different types of health indices. And increasingly, we are starting to deal with populations that have more chronic conditions. We're starting to look to expand to some of the populations that are able to participate in both Medicare and Medicaid, some of the age, blind, disabled populations, some of the long-term care populations. Clearly with the ACA, that's going to change as well, with the 138% being the determining factor for Medicaid. And so, we've been dealing with these issues for years with the traditional population that we serve. We're going to need to look to expand those goals that include reducing disparities to those other populations as well. But that's a core mission of Medicaid health plans.
Absolutely, that's great. And one thing that Medicaid does have going for it is we actually tend to have more of the data on race and ethnicity relative to the commercial health plan world. Yeah.
Exactly. In many cases, we're required to have that, compile that data.
Yes. Great. Well, another question for you. Specific to this conversation around the corrections population, how might health plans expand their reach to justice-involved populations, either inside the walls or outside the walls post-release?
Well, there is, unfortunately, there's a restriction that we work under. It's part of the Balanced Budget Act regulations that manage care. We cannot directly market to individuals. There are some exceptions to that in New York specifically, but really throughout the rest of the country, we can't directly market. And in fact, the most recent iteration of these regulations tightened those regulations even more so to include more restrictions on providers and their ability to try and influence enrollees in Medicaid towards certain plans. So health plans can market to the general population. In a lot of cases, what health plans try to do is target their activities in areas and places where it's fairly likely that either people who might be eligible might appear at that event, or people may know people who might appear at that event. A lot of community types of events we participate in. And so that way is a way for people to really get to know about health plans in particular. But in terms of actually enrolling themselves in a Medicaid health plan, usually they have to go through a totally different department within the state where they enroll, where they are educated about their choice of health plans that they have in that service area, and they actually try and enroll there. I think the good thing about the Affordable Care Act is that, generally speaking, I think you're going to see many more stakeholders try and educate people about how to become enrolled in a Medicaid health plan specifically. I mean, after all, there is a mandate to get coverage. And so that message is going out to everyone. And so I think that's going to cause people to pay more attention to getting enrolled. So I think that mandate actually is going to be very helpful with our own efforts as health plans to getting people enrolled in the system.
Absolutely. Carlisa in particular has mentioned a few times cultural competency and the need to ensure that the expansion population and the justice-involved subset of the expansion population in particular has access to culturally appropriate providers, whether from a corrections perspective or from a racial and ethnic cultural competency perspective. What's the role of the health plans here? What can health plans do to ensure that this cultural competency exists either at the plan or provider level?
Well, I think once again, states are very involved in setting up their Medicaid managed care systems. They have some flexibility under those same regulations. And in many cases, there are cultural competency requirements that we have to follow in our contracts. Now, what I will tell you is, while there aren't a lot of studies that show the impact of the Affordable Care Act on ex-prisoners, our assumption is that probably, as things stands right now, there are probably 700,000 prisoners that come back into the system on an annual basis. As it stands right now, probably about a third of those get access to Medicaid-related services. Now, I think our role is going to increase in that area because CMS's latest report, for those you don't know, that's the Center for Medicare and Medicaid Services. It shows that now over 50% of all of those enrolled in Medicaid is now enrolled in a Medicaid health plan. So we think that the way we're able to coordinate care with providers that are very used to that population, that are used to the cultural and language requirements that exist. In many cases, we have mandates to have services in many different types of languages, have oral interpreters, language interpreters, those types of things. We think we really, lead the way to make sure that services are provided in a very culturally competent manner. We have a Center for Best Practices that our organization created a couple of years ago, where we document some of those efforts that our health plans are engaged in to provide culturally competent services.
That's great. That's great. And one last question for you before we open it up to the participants for questions for our panelists. And Thomas, that is, do you think that addressing disparities in the community with efforts at the health plan level will have a direct impact on the criminal justice population more broadly? So in other words, does a disparities focus sort of by definition translate to an impact on justice-involved populations?
I think so. Although it might be kind of hard to track. But I think that the involvement of our health plans in a lot of community activity, there's a plan for existence in the Philadelphia area. They're involved in giving college scholarships, building playgrounds, hiring from the local community. Those types of efforts, I think, are going to help the criminal justice population. I used to serve on the board of an organization called the DC Prisoners Legal Services Project. And reentry definitely was a major focus of that organization. And clearly where you saw the business community involved in reentry, because a lot of times that's the issue. Those in the criminal justice system or have been in the criminal justice system obviously have barriers to get jobs from the business community. When you see that type of involvement, I think you can only help that population truly re-enter the system. So we think it definitely makes a difference in terms of addressing disparity-related issues.
Great, thank you. All right, Mike, do you want to?
I need a question. No. Mike, you got two questions here.
And can we only have just one question? Because, okay, thank you. My name is Dr. Lou Baxter, and I'm very happy to have the opportunity to be here. And this is a great exercise that Cochs has put together. So I really want to commend you. But there are a number of concerns that providers have with the ACA and with Medicaid as it currently operates in some states. I'm from the state of New Jersey. But I also am immediate past president of the American Society of Addiction Medicine, so I hear these comments from all of the states. And these are the things that I'd just like to put out here. We're concerned about benefits, specifically with the ability of the patients, the clients, the inmates to have MAT paid for. We're concerned about having, MAT is medication-assisted therapy. And some insurance plans, and it depends on which managed care agency is managing a Medicare plan, make it very difficult for patients who are reported to have benefits for medical assisted therapy, but sometimes they have difficulty accessing it. There's a pre-authorization hurdle in some instances. And for us, that's very frustrating because when our patients come in asking for help, and if they are appropriate for medication-assisted therapy, we want to be able to write the prescription and get them going. And when you can't do that, and especially if they come in on, let's say, Friday afternoon at 4 o'clock, and we're bogged down with this pre-authorization process, then the person may go out and relapse and actually die. I mean, I've had my own patients do that because of that stumbling block. And since I'm talking, I might as well hog up what I want to talk about. And, I'm sorry, huh? Okay, but hey, I'm very passionate, and this gets me going. So that's one issue. The other is payment for care to office visits. We talk about primary care physicians with this rollout of the ACA and patient-centered medical homes. More people will be receiving care from primary care offices. But currently, they don't get paid for those office visits. So that's another issue. And also the discussions about a length of treatment care.
What was the last one?
Length of time that we can treat people.
Gotcha.
No one says to a diabetic you can only be on insulin for 6 months. So those are some of the concerns that we as providers have.
Absolutely, and I might just direct some specific questions to some of our panelists here in response to the good list, healthy list of very relevant questions and concerns. One with specific regard to I think your second issue, which I would translate as adequacy of payment rates, primary care payment rates. Carrie, I'm not sure if you're familiar with the primary care bump. But you might want to speak to that for a moment.
Yeah, I mean, I don't know how familiar with that all of you are. The ACA does include a provision to increase primary care provider rates up to 100% of Medicare in 2009, I think. But no, current rates from the difference between 2009 and 2012. Rate, or 2013 rates, sorry. A lot of provisions in that act to keep track of. But so states are sort of grappling with how to implement that. The goal of implementing it is to sort of bump up or boost primary care access through payment rates. I mean, it's sort of difficult the way that they have sort of interpreted that provision, leaves it to states a little bit to determine the extent to which you sort of interpret it to the favor of the provider, which is what we're seeking to do, so that more providers will qualify to receive that increase. Unfortunately, it's only a 2-year increase, so there's no funding for it beyond the second year. So we will still be struggling with that, and I think all of you are aware that Medicaid payment rates are always kind of a contentious issue because Medicaid is always trying to contain costs, and yet we also know how important the rates are to the providers, and especially, in New Mexico, we have right now 1 in 4 New Mexicans is on Medicaid, and it will probably be 2 in 4 if we expand Medicaid. So we'll have approximately half or more of our population enrolled in Medicaid, so the rates become more important than ever in terms of providers sustaining their practices. So we recognize it, and the conversation is definitely happening, and it's just always difficult to sort of balance.
And one of the benefits of managed care, to turn to you, Thomas, is that the health plans that contract with states have additional flexibilities available to them within reasonable parameters to adjust rates accordingly. And
yeah, I mean, I will tell you that, I'm not going to necessarily say all health plans and Medicaid business do this, but certainly many of them actually pay their participating providers a little more than the fee structure, Medicaid fee structure in the state. So I think we really understand it's important for provider payment to be adequate. I think, frankly, any stakeholder in Medicaid is an advocate for those who participate in Medicaid from the provider perspective or from the plan perspective, quite frankly, because we have our own issues with the state to make sure that, rates are actuarially sound. But, we're a strong advocate for that. Now, what I will tell you is that there is a 2-year limit on this issue. And we have concerns about what's going to happen 2 years from now. And frankly, if you look at the national statistics, there aren't as many there aren't as many people going to medical school. And there are a lot of studies that show a lot of concern about what's going to happen in 2014 and whether or not we're going to have enough adequate providers in the system to handle this 16 million plus billion plus population that's going to be covered by Medicaid. But I can tell you, certainly from the plan perspective, we know it's important for providers to be paid adequately. On the other hand, I will tell you, we get real pressure from the state to control Medicaid costs. And clearly, if we don't receive adequately sound rates, actuarially sound rates, it makes it much more difficult for us to pay providers in the way that we'd like to.
Do you want to take another question?
Yeah. Hi. Okay, I'm Michelle May with the DC Department of Mental Health here, and I think our struggle is that Medicaid doesn't pay for a lot of the stuff that you need to reduce recidivism for justice-involved people, right? So a lot of the stuff that you need to do, visiting people in the jail, waiting in the line at the jail to see the person, spending 3 or 4 hours to pick someone up on release day, taking people to get their medications, housing applications, SSI applications, all the real stuff that really supports people in treatment is not covered under Medicaid. And so as we plan for getting more people on Medicaid, we also have to be looking at what other funding streams are going to sort of couple with that so that our providers can be reimbursed for the range of services that they have to provide. And so I'm wondering what other kinds of pots of money people are looking at to cover those kinds of expenses.
So, Tom, I'd like to reframe that question a little differently, if I could. In a world of capitation, in which your plans are capitated, and I have population-based outcomes for this very challenging population, do you see that there will be an openness or a willingness of plans to understand the relationship between outcomes and the kind of questions that you just asked, Michelle, and do we think that within that world of capitation, rather than in the transactional world, which folks are more familiar with, which is where I'm hearing you say you're not receiving payment, will there be an openness to understanding the relationship between positive outcomes and the kinds of services that I heard you describe? Is that another way to frame your question that would be fair?
Yeah, absolutely. But let me give you an experience of our industry. Because we do operate in the world of capitation. And one of the things that we are not reimbursed for in that world of capitation is weeding out people who don't qualify for Medicaid and actually who have fraudulently been put in the Medicaid system. We also are not reimbursed for people who do not adhere to the services that we recommend for them, or who do not show up for their appointments, even though in many cases we will have gone to their house to pick them up, to take them to the doctor. We want people to use the system, but when they don't, and when we've expended dollars to try and do that, we're not reimbursed for that. So I think that issue cuts a lot of ways. To be very honest with you, the way payment is going with many, if not all, public programs down the road is that payment is going to be based heavily on outcomes. And what that's going to mean is that a lot of those things that you think you should be reimbursed for individually, if the outcome eventually is not what your partner wants to see, then your payment's going to be reduced. So we're all very cognizant of that. But, just as you just brought up some services that you don't get reimbursed for, we're in the same position. We have to show that we're trying to get those enrollees to use the system. We're trying to make sure that they, adequately qualify for Medicaid. When we find out those things, which we think are good government things, quite frankly, we don't get reimbursed for those efforts. And so, I think the issue that you raise, it cuts a lot of different ways. And certainly that's something that we have to deal with internally as well.
One thing I might add is that, there may be an opportunity here to leverage some of the administrative dollars that are happening because, Medicaid does match some administrative activities. And so generally we haven't done that with corrections because those people haven't been eligible for Medicaid. So you haven't really been serving what we would call the Medicaid eligible population. But if you start to think about those dollars now as serving people who are going into Medicaid, there may be a way to approach that with your state that, outside of the managed care systems. That's sort of different from what the managed care plans would do, but that's sort of an administrative activity that Medicaid might be able to help you leverage dollars by pulling down some federal funding, matching funds. I think that's worth exploration of further.
Patrick? Oh, I'm sorry.
So in Maryland, just on that same question, where will the funds come from? We're trying to remind ourselves to think out of the box, or now I say get out of the box. And there's others that maybe we could work with who have resources, because there's lots of resources in our communities. Some of you may hate me for saying that. I don't think we're using them well. We're not connecting them. So there's duplication that should not be. So, for example, working with foundations, working with social services, because they're doing some of the same things that we're doing. So we're looking for ways to break the silos and connect the resources so we get more out of them. Now, I know that's just a philosophical issue, but to get out of the box, we might find the ability to pay for those kinds of things, community health workers making visits and others.
Hi, Patrick Duterte, Solano County. I just wanted to just echo what our president of Cochs has talked about. I think outcomes are really important because if it's just payments, we're wasting our time because the outcomes are really key. Now, our Medicaid members in Solano County belong to a county-operated health system, and we get we get a capitated rate, but we're run so effectively, it's only a 5% overhead, and there's also a risk pool. The providers get a certain payment, but that risk pool goes in there, and at the end of the year, if a provider actually has good outcomes from their patients, they get part of that risk pool. It's a way to go. I mean, I think it's the future of what we have to do. They have to give incentives to providers to really have good outcomes. It's been very effective and had great outcomes with our Medicaid clients in Solano County.
I think that, payment for performance ideally can work very well. However, I would caution our plans in Pennsylvania had an agreement to improve outcomes in a given area with the state. Those outcomes were achieved, and the state did not pay the plans. And so, unfortunately, our plans, and you can imagine they're reluctant to do this because this is their partner, this is who they signed their contract with, they had to sue the state to get the payment that they were supposed to get. So, if your partner does pay you for those outcomes, I mean, ideally that's what you want in the system, but that's an experience that our industry had in Pennsylvania.
Lucy Perez, the Cave Institute and the National Medical Association. From that standpoint, we struggled with pay for performance. And when you talk specifically of a population of justice survivors, you're talking about the sickest of the sick. And you're also asking providers to now incorporate them. So even their Herculean efforts just gets that particular patient and their family to baseline. And if you play bid whist, to even board. Okay? So we're going forward with a mentality that we expect something where we're all cutting costs. The issue is, you know, and it's in the words of Fidel Castro, you have to have the will.
Sure.
Is this our will? Because we're not just talking about them and us. Clearly, if anything occurred from the historic re-election of our beloved president, it would be that the essence of America cried out. The essence of America cried out. So now we're at a point where we do have the will. We have the will, and that we can push the envelope given that commitment. And that becomes key. So it's not just what's happened with the providers or what's happened with the plan, but what's happened as it relates to private industry. It's quiet as it's kept if we do not do something for the survivors of justice. We will be in trouble because they will not have an opportunity to get into free enterprise. So all of that becomes critically important, especially when we're talking about exchanges, and especially when we're talking about what we will market to them.
Well, Lark Wong from SAMHSA, Substance Abuse Mental Health Service Administration. And I have a question and a sub-question that relates to what Lucy just said much more eloquently than I'm going to ask it. So we're talking about disparities, and we've talked about the enrollment piece earlier today, talking about provider readiness or provider preparing and positioning providers to address some of what we might consider a disparities vulnerable population. So we're talking about people from different ethnic, racial populations. We're talking about people who have been jail, justice involved. We're talking about people who practitioners, providers often don't want to treat. They're jail-involved populations with substance use issues, mental health issues. These are challenging patients, challenging individuals. So I'm wondering, as we think about all those 16 million, 20 million people who are going to be now Medicaid enrolled or have health insurance in 2014, what are the incentives for providers to actually treat this very challenging, disparate population of jail-involved, ethnic, racial populations? So that's one question. So what are the concrete incentives there if we're going to really think about this in terms of disparities? The second thing is, are there mechanisms through Affordable Care Act that can begin to address some of what you eloquently talked of as all those other coordination services that are part of the unseen part of health delivery? And can we draw upon things like the health home provision, which is really looking at some of that coordination of services, but we can't target that for any particular population right now, but we can target it for the providers who might be involved in a health home network. So can you talk about how that might be also a two questions, the first one and then this one, as a potential strategy for perhaps finding incentives to treat the jail-involved population?
I'm going to love a stab at the second question, and would welcome any of you to join me in that one. Any volunteers for the question related to how do we create the right incentives for providers to willingly accept and engage this admittedly challenging population?
I would say that, this is just my opinion, I think treating the Medicaid population, not only representing the industry but having worked for a health plan locally, is extremely challenging. And I think, unfortunately, overall, I don't think the Affordable Care Act deals with many of those issues. Now, we can argue about the reasons for that. I think certainly the primary care bump is an effort to try and deal with at least one aspect of that. Unfortunately, as you know, there is a fiscal impact with legislation. The reason I think it's only a 2-year solution is because of the impact of extending it longer. And so the votes were only there for this bump to last 2 years. I think many of the other issues that, either I've brought up or that both of you brought up, by and large, I would say in the Act aren't specifically dealt with. Now, having said that, okay, there is a whole aspect of implementation with the Affordable Care Act that's going to be very critical leading up to 2014 and beyond. Because I can tell you, even though the Supreme Court has already made its decision about the Act, even though we just had the presidential election, I can tell you that there are still challenges to the Act that are out there. There are challenges to different sections of the Act. It is very likely that a federal law of this size will change in some way, shape, or form. There's discussions about including the Act in some of the deficit reduction talks that are taking place. I'm saying all of this to say, don't think it's over because the election happened, okay? If you're advocates in the Medicaid system or, with those who are reentering the system, if you were before, we're going to have to continue to do that because the Act was not a panacea to all of those issues that we've talked about, here on this panel. You've got to keep being an advocate for it and make your voices heard.
And just to weigh in on the health homes piece, so health homes is, for those of you who don't know, it's yet another provision within the Affordable Care Act. It's a new service that Medicaid programs can offer, and it's really about care coordination, care management, all of the glue and connections across the systems that we've been talking about in various conversations today that previously did not have a reimbursement methodology attached to it in most states. And now for states that elect to take on this service option, health homes provide that reimbursement pathway. However, they can only be targeted by chronic condition and to certain provider types and by geography within a state. That said, I think some states are doing some interesting things within those parameters that could be particularly useful for the populations that we're talking about here. For example, Vermont is in the final stages of drafting a health home plan that's focused on opiate addiction. And they are specifically designating health home providers that will serve high-risk opiate-addicted Medicaid beneficiaries. So again, it's not specifically targeting justice-involved populations, but I think we can safely assume that there will be a fair degree of overlap. And there's opportunities for that model to specifically bring in and explicitly require the connections across some of the systems that we've been talking about today. So that's just one example where I think some states are using this health homes opportunity as a vehicle to pursue some broader goals that involve some real cross-system partnerships that could be valuable for the purposes we're talking about today. And with that, I think we're probably getting booted off the stage. So.
Okay, so thank you. I'd like to thank the panelists and Allison for moderating and you for your questions. And now Steve is in the last panel. We're going to switch up. You can catch them if you got other questions, you can catch them in the audience.